Good morning, everyone. Thank you for your patience for the last minute or two. We apologize for some technical difficulties, and I will give folks a few seconds as you pile in from our virtual waiting room. Before I pass it for announcements, I'm hoping that maybe next week we'll have more from Workforce Health, but no updates today as of yet with regards to the COVID booster. And with that, I will pass it over to Dr. Cáceres, who has some announcements before she introduces our speaker. Dr. Cáceres.
Good morning, everyone. So I'm very excited to share with you all that October 1st is the second annual National Latino Physician Day. We're going to have a wonderful event at the Center for Academic Medicine at Stanford on Sunday. Yes, we're getting together on Sunday. It's going to be wonderful. Please come out and join and celebrate with us. There'll also be a panel that day that will be broadcast as a webinar that you can scan here to register. We have many events. I'm going to go through each of the reminders for you all. So this coming Tuesday is the final installment of the 1619 project with Dr. Salas and Dr. Dunn. So please scan and register if you would like to join the discussion. Next one. Many events, as I mentioned. So it's still Hispanic Heritage Month. And our colleagues over at La Clínica Latina over in psychiatry are having an event also at the CAM courtyard from 6 to 8 that evening. So consider joining them as well. And our next inclusion round for National Disability Employment Awareness Month is with Ola Ojebumi, who is an advocate. She has a wonderful story, a wonderful, compelling story, and many teachings to share with us. So please consider joining us for that. And almost last, on the same day, October 11th, which is Coming Out Day, is this year's LGBT, formerly known as the LGBT Forum, now known as an Evening of Queer Joy, which will be a wonderful event for building community. So please consider joining us for that. And last is a heads up for, as we round out Hispanic Heritage Month, Dr. Michael Rodriguez from UCLA will be coming to speak about language disparities, which is a topic that today's speaker knows a lot about as well. Oh, and last, if that was a bit of a whirlwind of everything going on. We have a lot more going on. So if you want to join our listserv, you'll get updates on everything that's going on. Oh, this was one I didn't know was coming, but this is just next week's Grand Rounds is in person. So please come join us as we hear from Dr. Chachanov. And today, so without further ado, give me a moment. So I have the honor of introducing Dr. Alicia Fernandez. She is Professor of Clinical Medicine at UCSF, Associate Dean for Population Health and Health Equity, and Director of the UCSF Latinx Center of Excellence. A graduate of Albert Einstein College of Medicine, she subsequently completed residency, chief residency, and research fellowship at UCSF, after which she joined their faculty. So to often talk about a triple threat in academic medicine, I would call her at least a quadruple threat, if not more. Not only is she a skilled clinician, oft-awarded educator and mentor locally and nationally, and a successfully funded researcher, she has also been recognized for her service to the community, most recently by the California Senate as a COVID-19 hero. I can do justice to her storied career in this short introduction. Like Winslow once told me during my residency here, we need more heroes in medicine. Dr. Fernandez is certainly one. We have asked her to share with us her reflections today. Thank you, Dr. Fernandez.
Thank you so much for that really lovely introduction, and thank you so much for inviting me. I am very pleased to be here, and I am very impressed by the array of speakers that you have. Sounds wonderful. So I am going to talk a little bit today about healthcare disparities. After I've been doing this now for quite a while, and I thought I would reflect a little bit on sort of where we are. Can I get a thumbs up? Can you see my screen? Is it in the right mode? Okay, great. So I thought that I would organize the talk very simply around 3 successes, 3 challenges, and some innovations that in my view are noteworthy. I hope it's all right that I will take a little bit of a detour through some of the language barriers work that I do, that my own research is in, to talk a little bit about more in depth about some of the challenges to health equity. But I want to start with this, which is the context in which we're having this conversation. As you all know, there was an almost unprecedented drop in life expectancy with COVID-19 that was particularly true for the Latino and Black communities, with over 3 years of life lost. And here, from the National Vital Statistics, we see that that loss has persisted through 2021, and in fact may even have increased a little bit in populations group. This is a very life expectancy has not declined this much since the Spanish influenza epidemic, and obviously represents a great failure in terms of our own public health and clinical care, but also in terms of equity. Unfortunately, that's not all there is to it. Maternal mortality rates have also been rising. Here we have it rising in total. This is from 2018, 19, 20, and 21. And as you all know, much rising in the African-American Black population, and rising in the Latino and white populations as well. That isn't all. We have increased all-cause mortality in children and adolescents. This is from a few months ago in JAMA, where mortality rates are going up since the 2019. And it's not about COVID. It is actually about what the CDC calls poisoning and suicide and homicide. And that is what the rest of us call ingestions. So with that context, I want to say that I'm not talking about equity in health today. I'm actually focusing on healthcare disparities. And obviously there are multiple causes of unequal health, especially social drivers of health and access to care. But today I'm really talking about inequities in the quality of care. And just want to point out that while we have made tremendous improvements in access to care, there remains significant, particularly for the Latino population, around a quarter remains uninsured. And we will see these numbers go up in every group starting this year as the Medicaid unwinding continues. But then, so now back to healthcare disparities. As you all probably remember, or you may not have been around then, but may know of the landmark report, Unequal Treatment, from the National Academy of Medicine, the IOM, was published in 2003, 20 years ago now. And they put forward this model for healthcare disparities. They talked about in populations with equal access to healthcare. So again, I'm not talking about access today. There is a difference in the quality of care that is made up of clinical appropriateness and needs and patient preferences, which is fine, but there is also a remainder difference, which they termed the healthcare disparity, and which they put forward as being in 2 boxes: the operation of the healthcare system and the interpersonal box, what happens in the room, discrimination, bias, stereotyping, and uncertainty. At the time that they wrote this, no one knew how large these boxes were. And now we know so much more, particularly around which box operates, has a more of an influence on a particular condition or a particular treatment. And that is indeed one of the great successes of the last several years. But I'm going to focus on one specific one, and that is the broad awareness of the role of individual clinicians in perpetuating or driving healthcare disparities. You may know the IOM report asks this: how could well-meaning, highly educated professionals working in their usual circumstances create a pattern of care that appears to be discriminatory? And 20 years of research have sorted some of that out. One important study that drove them to ask this was this one, which I think is now time to reintroduce to a new generation of clinicians. And this is the Kevin Schulman study in the New England Journal in 1999, in which he presented actors all reciting the identical script of chest pain, white actors and Black actors, and found that while Black and white men were equally referred onwards to angiography with their chest pain, Black women were under-referred, in this case, particularly older Black women. This study has been repeated many, many times. This was done with internists at an ACP conference, but it's been repeated many times with cardiologists, cardiology fellows, residents, and even medical students. And the finding is always the same, that Black women are under-referred for angina. Why was this study important? Why am I reintroducing it? Because it was one of the first sort of laboratory studies that cleanly showed us how bias, subconscious not play out in medical decision making. There were many more studies, such as this one, that showed that Black patients were rated as more likely to lack social support, failing to comply, and even less pleasant. And then there were studies that attempted to get at what was actually happening. How did this dynamic work its way out? This one is one of my favorites, because it was an audio tape study in the cath lab where people found, where the investigators found that as a physician came out of the cath lab to give the patient the results, less information was given to Black patients who asked fewer questions. And there was also less social comfort or bonding type statements. Oh, is your husband in the waiting room? Oh, don't worry. I know you've been lying there for a while. We'll get you out in time for the Giants game. Less of chatter. And it turns out that the amount of chatter is linked to the amount of questions, which is linked to the amount of information. And these are all associated, and any clinician is aware of that, and is aware how you can start in any one of these places. And but the thing that I found really striking about this is that when we have less social comfort, we give patients, it ends up with patients asking us fewer questions and receiving less voluntary information from us. And this has implications, of course, for clinical care. But what I'm highlighting here is that we're starting to understand a little bit more how these things work out. And on the patient side, there's also been some important studies. This one actually coming out of your institution, where some of your colleagues, economists and a physician from Boston, did what I thought was a great study. They recruited Black men in Oakland at a sort of a health fair type thing, and asked them to see a doctor about preventive care. The men were randomized to see either a Black man doctor or a non-Black man doctor. And before they saw the doctor, they had equal proclivity to having their blood pressure checked, or getting their weight checked and BMI calculated, cholesterol, etc. Randomization worked. After they saw the doctor, the men who saw the Black doctor were more likely to go ahead and actually do these procedures, which were also offered on site. And in particular, more likely to get their cholesterol or their diabetes checked, which obviously is an invasive test. Why was this important? For two reasons. One, the patients all rated, the participants all rated the doctors equally. In other words, surveys about did you like the doctor all showed that they liked the doctors. The doctors did a great job. There was no significant difference in how they rated the doctors or rated their interactions. But something about the encounter led the participants to actually be more likely to go ahead and actually do the tests. This isn't a new phenomenon, in as much as there were studies some 10 years ago showing that women were more likely to get a mammogram when it was a woman physician who recommended it rather than a man. But what is striking about this is that there was something in the interaction that we are unable to pinpoint with our research instruments. And I thought that was really fascinating, and it adds now to what we know, which is that clinicians contribute to health disparities. Some of that is around stereotype and bias, and that, as you all know, has led to this focus on implicit bias and diversity training and so on. We're still trying to figure out whether or not that actually has any impact. And now, but it also seems that actual representation, actually who you are, really seems to matter in terms of patient care in ways that we do not understand well. And I know that this is an obvious slide, but I make this point because I feel that lots of people continue to conflate addressing healthcare disparities and addressing diversity, equity, and inclusion. And these are very different, and both are important. We need to address diversity, equity, and inclusion because of simple issues actually, we need to address both of these things because of simple issues of social justice. But they do overlap in as much as who is in the healthcare workforce, and most of the studies have been done on physicians, actually really has impact in terms of patient care and patient outcomes. So the first big success is that there is now broad awareness of this. And when we make arguments around diversity in California and throughout the country in medicine, our arguments are we need more diversity in medicine because of the impact on patients, which is a different argument than, say, given the context of the recent Supreme Court decision, it's a different context than that diversity is good for the learning environment. And that, I think, is a strikingly important success. The second huge success has been the elimination of some acute care disparities. More than 20 years ago, many of these studies were on the treatment of MIs. And here is a slide from AHRQ showing that everyone got better, and disparities in deaths from an acute MI were have been almost eliminated. A study in 2018 confirmed this, and this has been while disrupted with the COVID epidemic. This is an incredible achievement. So, how was this accomplished? And I think clinicians who remember the last 20 years know that there was an enormous body of research that examined every single step in from when a patient has chest pain all the way until hospital discharge, seeing where there were disparities, where care could be improved. And out of the research came very clear guidelines that established clinical norms, how many hours a person, how long after a person presents, should they get an aspirin. And part of that involved the reorganization of the healthcare system, in which regionalization became important, and this phenomenon of hospitals, of ambulances bypassing some community hospitals in order to go to a hospital with a cath lab on site became formalized and accepted. And this was done partly through the usual clinical guidelines, but it was also done very importantly because of the involvement of the American Heart Association and many other aspects of the sort of ecosystem of medicine, which really pushed for this tremendous change. And this tremendous change resulted in the elimination of racial and ethnic disparities in the treatment of MI. Very, very important. Out of that comes more generalizable learning, which is that quality improvement can really work on disparities. But we have examples of quality improvement, such as the one I just showed, where everyone got better and the gap closed. We have examples where everyone gets better and the gap stays the same, flu shots. We have examples where both groups or all groups get better, and yet the gap widens, which pretty much happens with every new technology or every new medication. And occasionally we have examples when one group stays the same and one group gets better. And this happens only when there's a very focused, very targeted interventions. So what do we know? We know now what we didn't 20 years ago, which is that quality improvement, the impact of sort of general NOS quality improvement is highly variable. But at the same time, we know that targeted, thoughtful interventions that are backed by research can actually eliminate some healthcare disparities. The mammogram gap between Black women and white women has been eliminated in the United States, another huge achievement. Unfortunately, death from breast cancer has not been eliminated, but at least we're screening at the same rates in those two groups. So again, quality improvement and healthcare quality improvement can work when it's done with a thoughtful eye with respect to healthcare disparities. What's our third success? I think that there is now, particularly in the last 10 years, much increased awareness of social drivers of health, so-called social determinants of health, and the need that for multi-level interventions, be that the interventions that also address the social drivers of health, or importantly, interventions within the healthcare system that operate on multiple levels, not just on the clinician level. So that we have frameworks like this from the NIH, from NIMHD, that show multiple levels of influence and multiple domains of influence, or a schematic like this, where we look at things as the individual, work, neighborhood, and country. This is from Ana Diaz-Ruz, and I particularly like this framework. But my point here is that we are now routinely looking at interventions and doing research that operates on multiple levels. Huge step forward compared to, say, 15 years ago. But with that good news, and remembering the context that I showed you earlier, I want to talk a little bit on the challenges. One of the primary challenges that I see is a real resistance to reorganizing care. And what we saw in ways with acute MIs seems to be in many ways an outlier. Let me show you. This, in fact, is what's happened with heart failure. Everyone got better. The gap really did not change. And we've also seen some success with chronic disease. So the point that I wanted to make is that it is much easier, and we are much more successful at dealing with an acute disease process than we are with chronic disease. And of course, as we know, that's true in everything we do in medicine. So here is a lot of success at Kaiser. They were able to improve care during 2020, 2021, 22, working with CBOs, being out in the community, doing so much more to educate and provide lower barrier access to care, both for testing and for vaccinations. So we'll see where this goes. And the final thing that I will raise is where we are with use of technology to simplify and address some of the barriers of care, such as interpretation. And unfortunately, we don't yet have what I, as a lifelong Star Trek fan, would want, which is a machine that I hold in my hand, and no matter what the language is, Klingon, Romulan, or a new species, I have a universal translator that will automatically work. Instead, we have things like Google Translate. And we did a study here where we examined instructions from our emergency rooms at San Francisco General and at UCSF Health. We took, I think, 50 encounters, the actual discharge instructions that the resident or the attending typed in to the patient after visit summary. And we put them through Google Translate into Spanish and Chinese, and then had professional translators back translate them. And we found that for many things, it actually worked surprisingly well, particularly for Spanish. Unfortunately, if the clinician used an atypical or used a word in an atypical fashion, here our resident wrote, hold a kidney medicine until you have a chance to speak with your kidney doctor. Probably not the best way to give instructions in English. But the back translation in Spanish was keep the medication for the kidney, as it was for Chinese, as it was in Chinese, where held, it was translated as hold on. We also found, surprisingly, both spelling and grammatical anomalies, even when the information was written correctly in English. And here, the lidocaine is plugged during 12 hours. It is turned off during 12. And here, the names of the medicines were incorrectly back translated. We ended up concluding that Google Translate should not be used routinely and should only be used with very simple declarative sentences, and that every time machine translation is used, a drop-in should go down saying saying that the English is correct. In other words, the patient should always have access to the English as well as the machine translated material. And the machine translated material should indicate that it was machine translated and that the English is the correct version. I was still hoping for universal translate. So working with Juan Lee, one of our young anesthesia faculty, we looked at simple sentences in PACUs where it's often hard and people often don't use an interpreter. And we looked at all of the systems, Apple, Google, Microsoft, and compared them to a human interpretation using a non-inferiority model. And what we found is that while this English to Spanish wasn't bad, with about 70 to 80% acceptability rate, Spanish to English was terrible, resulting in one-way communication. And why is that? Because when the patient says, why does my leg hurt? ¿Por qué me duele la pierna? The machine interprets it as because my leg hurts, because in Spanish, por qué can be why, or it can be because. And it was even worse in Mandarin to English. So unfortunately, we are not there yet. So in conclusion, and I hope we have a little bit of time for comments and questions, there has been tremendous, remarkable progress in addressing some healthcare disparities, particularly in acute care. There has also been tremendous movement in how many people throughout the country and clinicians throughout the country think about health equity and healthcare disparities, both understanding the role of individual clinicians, that individual clinicians have a role, but also starting to understand more about how quality improvement works and and what we need to do. On the other hand, the lack of engagement with the broader health ecosystem has really slowed progress, the lack of regulatory and financial drivers. And it has really slowed progress. And this is nowhere more apparent than in the treatment of chronic disease, where we're putting more and more onto the patients and unfortunately have been slow to reorganize care in a way that makes it more effective for so many of our patients. We see not only that we've been slow, but there's a real resistance to reorganizing care. And that is, I think, true for even the most advanced and progressive healthcare systems. We have also seen a strong resistance to diversity in medicine. And this, of course, we now have the Supreme Court decision, but we also know that, diversity has been very, very slow, particularly in upper echelons. On the other hand, I hope you were at least intrigued and heartened by the bright lights that I showed, the innovation that is going on, and the many pilots, and I know there's many, many on your campus that are trying to address this. So with that, let me say thank you and hope we can have at least a few minutes for questions. I hope I didn't talk too fast. It's a problem for me.
Thank you so much, Dr. Fernandez. That was such a tour de force of review of the past few years in the work, and giving us a sense of the directions to go. We do have some questions, so I will read some of them out loud. One is just a clarification question of the definition of language concordant MD. Is it a person who's a native speaker, or it's just someone who took classes in the language, and has that been parsed out?
What a great question. What a great question. And so the answer is we don't know. But in this study, what we did is we, building on other work that we've done, when you ask physicians specifically to talk about how well do you speak Spanish, and then you ask their patients, does your doctor speak Spanish? When we offer physicians 5 choices, none, a little, fair, very good, and excellent. Physicians who say excellent or very good, their patients do agree that they speak Spanish. But physicians who say fair, which is usually the modal quality, modal box, only half of their patients agree that their doctor speaks Spanish. And that's because as physicians, we tend to overrate our skills in lots of things, our ability to read EKGs, our ability to hear murmurs, et cetera, all of which has been well documented. So where most healthcare systems are going is toward exams and certifications of their workforce, including their physician workforce. And many health systems are giving extra pay because, after all, that person doesn't need an interpreter to talk to the patient, but and saves the system money. So Kaiser Permanente in Southern California pays a bonus to clinicians who are certified, and they do have to take a test, certified to speak the language. Great question.
Thank you. As a near and dear to my heart, as a language concordant primary care Spanish speaking physician, I've personally experienced that switch from a discordant PCP to me, and improvement in their diabetes. So it's very interesting to see it laid out in the data. And piggyback off of that, I'm going to read a question from my colleague, Dr. Fadki, who is our director for population health and primary care, and who's very engaged in this work with me. And she says, thank you for this incredible talk. Is there any data on appointment duration and effectiveness of interpreted visits? Any advocacy information recommending longer visits for language non-concordant provider-patient pairs? And that was one of the questions I had too, as part of this workplace conditions for physicians and other healthcare providers, is we don't have enough time, that hassle factor that you were talking about.
Right, exactly. Great question. Another great question. Yes, a little bit. There was data showing, interpreted conversations didn't take that much longer. And that was true. And the reason they didn't take that much longer is because physicians chose not to talk about lots of things. So again, the example of in diabetes, if I focus my conversation to take metformin twice a day, maybe it doesn't take that much longer, even though everything's being repeated twice. But if I actually want to say, let's talk about what you're drinking, let's talk about what you're eating, then that will obviously take longer. So at UCSF Health, the primary care clinic now doubles the amount of time for any LEP patient who's being seen with an interpreter. And I think they've gone from 20-minute visits to 40-minute visits. At San Francisco General, where over 30% of our patients speak another language, we have not done that because we would not be able to provide access to our patients. So really something very much to consider. And that experiment is being looked at carefully at UCSF Health in order to see if that works, results in better outcomes.
I know we're almost at time, but if you're all right for a couple of minutes, I'll go through a few more. Kind of dovetailing off that, Dr. Rosalind Vasquez asks, what suggestions do you have for more regulatory and financial drivers incentives?
What's the evidence? Is that the question?
What suggestions do you have for more regulations and financial
What suggestions? I think that JCHO should be auditing hospitals to not only to see whether or not an interpreter was used during informed consent, which they now do, but really looking to see whether or not there's documentation of interpreter use on day 2 or day 3 of hospitalization. So one suggestion is once a day, if you're sick enough to be in the hospital, you should have access to talking to your clinical team. Similarly, I think nurses in a 12-hour shift should at least once talk to the patient. So I'm not talking about a ceiling, I'm talking about a floor. So that is a regulatory issue that JCHO could take a lot of leadership on. Similarly, I think that payers need to put into effect both financial incentives and financial penalties for reorganizing care and making it easier for patients to have language access, be it a language concordant care or be it through an interpreter.
You talked a little bit about the role of technology and new medicines. So I often worry about this, is it everyone's all excited, especially here, about new advances, and I always worry about the widening disparity gap. We had a question about, do you think AI or other technological solutions, which you talked about, that can help improve language barriers, can help automate? A little bit more about that.
Yeah, we're actually have a study in play right now where we're repeating our Google Translate study from a number of years ago using several AI platforms. And we are hoping to see whether AI can help us in 2 ways. One is eliminating jargon, eliminating the metformin, and also whether once that jargon is eliminated, whether AI could prove better at translation. So I am hopeful. I do think we're not that far away from being able to do this, and I do think more work needs to be done in this area. I'm doing that, and obviously always happy to have collaborations.
Wonderful. I'm going to go through, we have so many questions, but I'm going to go just through a couple more. So Dr. Yuen Kim, thanks you for your rigor and your candor. Do you think including second language training in med school or other curricula would be helpful? This is interesting because we're considering pushing forward legislation to improve kind of CME access for additional languages.
Yes, so I do think so, but I think that with a couple of important caveats. One is people need to start at an intermediate or advanced level so that they can learn the medical terminology. My kid speaks Spanish, but she grew up here. She has no clue how to say spleen in Spanish, right? So she would be fine, but not fine to say see patients or do any clinical work. So I do think kids like that, heritage speakers, should be taking medical Spanish courses. Medical schools should be providing them. So that's one. But 2, we need to be testing them. In other words, just as we say, okay, yes, you are competent to read EKGs. We've looked at you. We need to be testing people using formal testing which exists and is, not all that expensive, to be able to say, okay, yeah, you now can speak enough Spanish to or whatever language to see patients. And I believe that the University of California system should give priority to applicants who serve one of California's threshold languages. So that's one. And two, we should be helping, and who can demonstrate that through examination. And two, we should be helping heritage speakers, and we have so many in California, get to actual medical fluency.
Hear that as a born in the U.S. Spanish speaker. I believe the University of Texas does do exactly that.
Yes, many systems do.
And I have another question. You talked a lot about diabetes, but do you know of any initiatives for lowering barrier for addiction care? Question for Dr. Angie Chen, one of our
or addiction care. Yeah, let me tell you about one of my fantastic colleagues who works with me at the UCSF Latinx Center of Excellence. This is Dr. Marlene Martin, and she just got funding from the California Healthcare Foundation to train promotoras, to train community health workers in talking to community members about all of the new addiction services that we can offer, including, very importantly, for alcohol, and the role of some of the new medications, both for alcohol, but for other addiction services. And we are evaluating that program is just getting off the ground. We're evaluating that program to see whether or not providing cultural and language concordant education in the community will make a difference.
Dr. Martin is a graduate of Stanford Med School.
Yes, she is a graduate of Stanford Med School. You have many outstanding people there.
Yeah, and I want to wrap up with just some of a technical question, and maybe to globalize. We talked a lot about Spanish, but there was a technical question about the disparities with language. Is it by immigration status, regardless of language fluency?
Great question. We only looked at immigration study in another paper. We don't have the people who are getting care at Kaiser typically are documented or are working and have access to Kaiser insurance through that mechanism. We did a large study in here in the Bay Area and in Chicago some years ago to see whether or not undocumented Latinos and documented Latinos who are getting care in the same system have different outcomes, particularly with respect to their diabetes. And we found that they do not. They did not. However, undocumented people often don't enter the healthcare system. So we studied people who had entered the healthcare system. What we learned during COVID is that even in San Francisco, sanctuary city in a sanctuary state, many people did not come and see us with their COVID until they were nearing intubation. And when you ask them finally what happened, and we did a study on this that you can see in JAMA Network Open, what happened is that a lot of them were undocumented and were scared to come to the hospital. And I'm like, wait, what are you talking about? This is San Francisco. Everyone knows that San Francisco General is open to all. But that's not true. Everyone doesn't know it. And we have to keep telling people that we are open to all. I can see that we need to end, but thank you so very much for the invitation. I hope this has been interesting to all of you. And again, there's so many wonderful people there. I know that we should be doing more collaborations to improve the health of everyone in the Bay Area and Northern California. So thank you very much.
Thank you, Dr. Fernandez.
Thank you so much, Dr. Fernandez. Actually, it was a wonderful way to close and just to remind us of how close we are and collaboration. Thanks to everyone who stuck with us a few extra minutes. And thank you all for just joining us in this series for Women in Medicine Month, for Hispanic Heritage Month as we continue. Next week, join us in person for Dr. Harvey Chochnov, who'll be joining us in person next week. Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.